Hi, I'm Dr. Stephen Liu, Director of Thoracic Oncology at Georgetown University. At ASCO 2025, we saw some major updates in small cell lung cancer, with two phase 3 trials meeting their primary endpoint and changing the standard of care. The first was the IMFORTE study, a phase 3 trial of maintenance lurbinectedin for small cell lung cancer. Maintenance strategies are very logical. We know that small cell lung cancer responds well to chemotherapy. Response rates are very high, but most patients do relapse fairly quickly. The addition of immunotherapy, either atezolizumab or durvalumab, improves survival, but most patients still do relapse, despite the fact that relapse is predicted, it is anticipated, and that we have active agents in the second line and beyond setting. 50% of patients do not receive second line therapy, and only 25% of patients receive third line. It's primarily because when small cell lung cancer relapses, it leaves patients too sick, too ill to receive any further therapy. A maintenance strategy, introducing treatment earlier, is a proactive one rather than reacting to the relapse. But despite how logical a maintenance approach is, there's never been a positive maintenance trial until this one. In this study, patients with untreated small cell lung cancer, extensive stage, all received standard carboplatin plus etoposide plus atezolizumab. At the end of induction, which is 4 cycles, patients that did not progress and still had a performance status of 0 to 1 were then randomized to standard atezolizumab maintenance alone or atezolizumab plus lurbinectedin, given at a dose of 3.2 milligrams per meter squared with primary G-CSF prophylaxis. What we saw in the study was that the addition of lurbinectedin improved progression-free survival. The median 2.1 months with atezolizumab, 5.4 months with lurbinectedin plus atezolizumab. Remember, those absolute numbers are measured from the time of maintenance. They do not include the 3.2 months of induction therapy. The PFS hazard ratio 0.54. The 6-month PFS rate improved from 19% to 41%. A significant improvement in progression-free survival, but not really a surprise. You're adding an active agent. We expect an increase in progression-free survival. We expect that to come at an increase in toxicity. We saw that as well. The grade 3 treatment-related adverse events increasing from 5.8% with atezolizumab to 25.6% with lurbinectedin plus atezolizumab. Fortunately, many of these were laboratory abnormalities. If we look, for example, at the rate of discontinuation of any drug due to treatment-related adverse event, only 6% with lurbinectedin plus atezolizumab compared to 3% with atezolizumab alone. So often those adverse events not really leading to a stopping of treatment. We expect an increase in PFS and increase in toxicity. The real question with the maintenance strategy, does this improve survival? And here it did. The median survival increased from 10.6 to 13.2. The 1-year survival rate, 44% versus 56%. Hazard ratio, 0.73. Similar hazard ratio we see with the addition of atezolizumab or durvalumab to chemotherapy in extensive stage with Empower 133 or Caspian. Even Adriatic had the exact same overall survival hazard ratio, 0.73. Maintenance lurbinectedin before progression improved survival. Still, though, many patients do relapse. Most patients do relapse and are in need of second-line therapy at progression. What do we use in that setting? Our standard historically had been chemotherapy. The DeLLphi-304 study redefined that second-line option. This was a second-line study of patients that had relapsed after platinum-based chemotherapy, most of whom received immunotherapy as well. Patients are randomized to receive tarlatamab, a DLL3 T-cell engager, or chemotherapy. While the chemotherapy options were topotecan, lurbinectedin, or amrubicin, topotecan was given by far to most patients. Relatively fewer patients received lurbinectedin or amrubicin. And here, tarlatamab improved outcomes. The PFS was a modest improvement from 3.7 months to 4.2. That's a PFS hazard ratio of 0.71, but there was a survival benefit, increasing from 8.3 to 13.6, OS hazard ratio 0.60. Response rate increased from 20% to 35%. Most patients here had received topotecan, not the ideal treatment for a platinum-resistant setting, and about 45% of patients were platinum-resistant. Even in platinum-sensitive, platinum re-challenge was superior to topotecan. But here, the OS hazard ratio 0.60 really is unrefutable. This becomes our second-line option when available to patients. There were toxicities, but actually fewer grade 3 treatment-related adverse events, 27%. Compare that to 62% with chemotherapy like topotecan. There was a high rate of cytokine release syndrome with a CRS rate of 56%. ICANS, fortunately, pretty low at 6%. But this becomes our standard of care where available in that second-line setting. Now, our standard of care, in my opinion, for small cell lung cancer would be chemotherapy plus a PD-L1 inhibitor, and then maintenance lurbinectedin plus atezolizumab, and at relapse, for those who do relapse in the second-line setting, tarlatamab. We have more agents to come, antibody-drug conjugates, tri-specific T-cell engagers, and so the field continues to be redefined, but a new standard of care after ASCO 2025.